Very well, it's time for your health segment, and tonight we are focusing on HIV and AIDS, and particularly the ongoing survey that is being undertaken by the government, a door-to-door survey seeking to find out the prevalence rate of HIV and AIDS that is being done under the Kenya Population-Based HIV Impact Assessment Survey. And we're just trying to find out what is this survey all about and how is it that we can be able to participate, and of what benefit is it to us as a country and, of course, to you as an individual. Just asking yourself, when was the last time that you had an HIV test? Perhaps this is a good time for you to tap into this particular survey. And for more insights on this, we are now joined by Dr. Lilly Nyaga from NASCOP, that is the National AIDS and STI Control Program, as well as Nelson Otuoma from NEPHAK, that is the network of persons living with HIV and AIDS in Kenya. Thank you very much for coming to our show this evening. And I want to start with you, Dr. The first case of HIV and AIDS was reported in the country in the 80s. Is HIV and AIDS still a threat 30 years later?
Thank you, first of all, Catherine. I want to appreciate the opportunity to actually talk to Kenyans about the survey that we're undertaking. And yes, HIV is still a threat, because currently we are estimated to have 1.5 million people living with HIV. Mm-hmm. We have identified around 1.1 million Kenyans, which means there's still close to 500,000 Kenyans out there who do not know their HIV status. HIV, as you know, comes with a lot of socio-economic stress, mm-hmm. Especially in the country, because Kenya is actually number 4 in terms of leading with people living with HIV. So we still have a long way to go.
Mm-hmm. All right. You work with persons who are living with persons affected by HIV and AIDS. In terms of access to treatment, what would you say is the status?
Thank you very much. I think in Kenya right now, access to treatment for HIV ARVs are available. Mm-hmm. And anytime, I think NASCOP has the strategy of testing and treating. So you test today. If you are ready, then you will be enrolled on treatment. We mm-hmm. don't have any problem with stock out. But I also want to briefly talk about your first question. Mm-hmm. If HIV is still a challenge, mm-hmm. and it is, because in as much as the government and their partners is providing ARVs free of charge, they are paying. And you need 47,000 per person per year. Mm-hmm. And we are talking about 1.5 million. Already 1.3 million are on treatment. Mm-hmm. And each day they have to take that medication the government is paying and their partners. Mm-hmm. Yeah.
But access to treatment, does it also come with the nutritional bit of it? Because the major challenge is, how do you take ARVs on an empty stomach?
You know, you don't wait to take ARVs on an empty stomach, because NASCOP is going to provide you with the testing when you are still walking and working. Mm-hmm. It's not like in the past when people used to be bedridden, although there's mm-hmm. a challenge of stigma, so some people are tested really very late. Mm-hmm. Now, there is special consideration, therapeutic nutritional needs that are met by partners. One of them is Global Fund through NASCOP. If you are really very sick, if you have co-infection like with TB, like even children, mm-hmm. but it is not available for everybody. But if you are just tested when you are still fine, you don't need any additional food apart from the food that you take every day to take these ARVs. One last point to explain in that area, when treatment started for HIV, people mm-hmm. used to take cocktail. Mm-hmm. So many medication, mm-hmm. and they used to have adverse side effects,
yes.
and it used to burn the stomach and so on and so forth. So people really needed special food mm-hmm. to take ARVs. But at the moment, we have better, safer, simpler ARVs that you can take with the water or you can take with the food, and you take one pill a day, the mm-hmm. same way you would take
so
Panadol.
So they're not as many as they were before.
Yes.
Mm-hmm. Yeah. All right. So even as you know, we are talking about a lot of people now having access to treatment for HIV and AIDS. In terms of the challenges that you're facing, the uptick, are mm-hmm. people responding well towards treatment?
Okay, thank you for that question. As I mentioned, we have 1.5 million Kenyans living with HIV. That is the number that is estimated in this country. So far, we have been able to identify 1.1 million. And I must say that number was actually escalated especially by the fact that Kenya adopted the test and treat strategy, which means that when a person gets tested and is found to be HIV infected, then they are initiated on ART immediately.
So they don't have to wait.
As opposed to what we used to do before, where we used to wait for CD4 counts and such factors to actually consider to initiate a person on treatment. So right now, everybody who actually knows their status ideally should be on treatment. So how are we doing? Mm-hmm. in terms of identification, like getting to bring these people on board, it needs to start with people knowing their HIV status.
Yes.
So as you can hear, I'm saying we have 1.1 million, which means we have 400,000 Kenyans who don't know their HIV status. Of the people that we have been able to identify, close to 99% of them have been put on treatment. The 1% would be maybe the people who are still out there, who are probably still fearing, they have not come back to the facilities. But in terms of identifying and linkage, we are doing very well. So our main challenge right now as a country is actually to be able to bring the 400,000 people to get to know their HIV status. Yeah.
Knowing your status, I mean, VCT centers was one of the ways that perhaps the government was very keen on trying to, to encourage people to get to know their status. Are people really going to these particular facilities to get tested for HIV? Or?
Yeah. I think the bulk of 1.1 million who are on treatment were identified through VCTs. But because not everybody will go, HIV is still stigmatized, and some people also still have fear because we've not educated everybody on the health benefits of testing and knowing your status of being on treatment. Some people still go to facilities when actually they're really very sick, and they don't mention HIV. They say malaria is bad. They say maybe I'm having TB because I'm coughing.
Now the opportunistic infection.
Yes. Now when they go to a facility, again it is upon the people in the clinician, the nurse and the doctor to talk to them and manage their malaria that they brought to them, but in addition try to educate them about some other condition that may be bringing this malaria or this TB. And NASCOP has trained doctors all over the country so that they can educate people. So when women present in facilities during ANC for delivery or just clinics, or when I keep on frequenting a hospital that I have malaria which is not getting cured, they will deal with my malaria, but they ask me and educate me, and then it is still my choice to decide whether I want to be tested. And therein lies one problem.
The voluntary aspect.
The voluntary aspect, because of stigma. So very few people still are finding it difficult to volunteer to that test. And that is why we've made progress with many people on ARVs, but still some people are dying. But that is the work that NEPHAK do, so that we educate people, so that we understand that this is not a death sentence and it is a chronic condition, and as long as you accept you are on treatment, you don't even need to talk about your status. You don't need to disclose.
So stigma is the greatest barrier perhaps that you're still facing in trying to do advocacy.
Yes.
All right, let's talk about the survey, the ongoing survey that you're doing. What is it about? How is it supposed to work, the door-to-door campaign?
Okay, so KENFIA stands for Kenya Population-Based HIV Impact Assessment, and as the name suggests, it's really a population-based survey, which means we are going door to door with an aim to determine the number of people that are living with HIV in this country. We also want to be able to determine the new HIV infections in the country, and finally, we want to know the number of people who have been on an efficacious HIV treatment, which means we want to know how many of the HIV-infected people have achieved HIV viral suppression. So this is a nationwide survey. We are going to go to 47 counties. We anticipate to go to up to 20,000 households. And we also anticipate to reach up to approximately 35,000 Kenyans. Yeah.
35,000 Kenyans. In terms of counseling, perhaps, what is the strategy? Because we always know that when you go for HIV treatment, testing, most people, you have to go through the counseling in the event that perhaps you test positive. Tell us about that. Will that be happening?
Before I go into that, let me just state something for the sake of Kenyans who may be watching or listening to this. KENFIA is not about people living with HIV. The reason why NASCOP and the team, it is a team, not just NASCOP, is coming to the household is because they don't know the status of people. And as Dr. Lilly has explained, they are coming to know how many Kenyans possibly could be infected with HIV and how many are on treatment or that treatment is working. When the treatment is working, the viral load is down. We say virtually suppressed viral load. But to your question, we in NEPHAK are non-government, and we are supporting NASCOP in this because of the procedures they are following. First, when they come to a household, when the household is sampled by the scientists, they come and introduce themselves. Now, in the introduction, we know and they educate you more about KenFIA. But the first step for those who will enroll in this study is counseling. So in the team, they have a team that are visiting homes. And in the team, they are trained counselors. They were trained a long time ago, but for the sake of this study, they have been provided with refresher training. And they have a clinician, and they have a team that will explain and tell you. So pre-test counseling is there. And when we say we are doing testing at home, it does not mean we sit around table and draw your blood and show the results there. It
so
is
upon you. Standing at the door.
It is upon you at the head of the household to say, are you comfortable for us to do this? Because even when it comes, negative or positive, it is never communicated verbally. There is a way in which you read it, and your comfort later on you may disclose, even if it is your partner. And because that is following consent, privacy, confidentiality, for us, the reason why we are supporting this, it is like an hospital has come home.
But now with perhaps the issues around stigma, I mean, what makes you think people will be willing to participate in this exercise? Because when you come and introduce yourself and say we are doing a survey on HIV and AIDS, and everyone will be like,
okay. So first of all, this is not a survey that is the first of its kind. We have done two such surveys in the past. These are usually 5-yearly surveys. In the past, we have called them KAIS, which used to stand for Kenya AIDS Indicator Survey. We did the first in 2007. We did the other one in 2012. And now this is just a build on to it, only that the name has changed.
Yes.
And in the past, we have had quite a good acceptance rate in terms of people accepting to actually participate in the survey. So there are several things that Kenyans first need to know. This survey is broad in the fact that in as much as we're doing HIV testing, we are also going beyond HIV and doing a syphilis testing, hepatitis, and even doing nutritional status for mothers, pregnant mothers and children who are below 5 years. So the survey basically involves like taking you through a series of questions just to be able to understand your experience with the healthcare system. Like for the people who have probably gone to, maybe they've had TB, were they treated? Did they complete their TB medication? Like for the mothers, did they attend ANC, the clinics, and were they, tested for HIV? Did they get medication and all those things? So it's really broad, taking you through a series of questions. And then at the very end, we request to offer you a HIV test and the additional tests, and they are very voluntary. It's up to that person to actually accept to participate.
So for purposes of just security, how will the people who come to my door look like? Will they be dressed in certain clothes? Because this is also a window where people who want to do funny things can also take
Sure. So KenFIA staff will be dressed in a KenFIA t-shirt, which is actually well labeled. They also have a badge that actually has their name and even an ID. They also have, of course, they'll be carrying the tablets, and there is a very clear way of being able to identify these people. These people are not coming to your household without your information. So first we have a group of people we are calling mobilizers, who are also well identified in terms of how they are dressed, who come 5 to 7 days prior to the day the actual interview takes place. And they come explain to you that there's a survey that Kenya is going to be undertaking, and these are your benefits for participating. And then 7 days later, now the KenFIA, the actual data collectors will come to your house, and they'll have actually even made an appointment so that they can be able to find majority of the household members in their house.
Okay, I'm informed our time is up, but Nelson, I'll just give you a couple of minutes. In terms of incentives, are there any particular incentives that perhaps you'll be giving to Kenyans to make them more receptive towards the survey? As we wind up.
I think because this is a national survey, the largest incentive you get as a Kenyan is the public health incentives, that you are able to know what level of HIV do we have in this country. So every Kenyan benefits. But at the individual level, remember when you go to a facility, you may go for TB or malaria, or you may go for HIV, but they help with that health check. So that is why I started by saying this is an hospital coming home. For people who will be testing positive, you are guaranteed that you will be on treatment. And you are talking about stigma initially. People used to stigmatize sickness and death. This survey and treatment is warding off that sickness and death. When I come to your home, you are not sick. The following day, you just go to your farm. Nobody will stigmatize you, and nobody will know your result. And then for those who will test positive, the fact that you are taking small amount of blood to go for further analysis. Remember, STIs will be checked. Remember, drug resistance will be checked. For those who have HIV, viral load will be checked. Viral load is what people living with HIV fight for every day so that they know how they are doing on treatment.
They're doing it. Yeah. All right. Thank you very much. Unfortunately, we've run out of time, but we do appreciate you shedding light on what you're doing in terms of trying to collect data to guide some of the programs as regards HIV and AIDS. Well, we have been talking to Dr. Lilly Nyaga from NASCOP as well as Nelson Otuoma from NEPHAK, just shedding light on an ongoing HIV/AIDS survey door-to-door campaign. So in the event that you find people from NASCOP as well as NEPHAK and other organizations coming to your home, then be prepared. At least you know what they're coming to do. This is where we put an end to Your Health, but O'Brien Kimani is on standby for the day's business, so stay tuned.